Welcome to the use of breastfeeding tools and paste bottle feeding, the fourth and final webinar in our four-part breastfeeding skill session webinar series. My name is Amy Gohl, and I'm the Director of Education for the Partnership for Maternal and Child Health of Northern New Jersey. The partnership is providing today's program. A few pieces of information before I introduce our speakers. The speakers and planners have no relevant conflicts of interest to disclose. To receive a certificate of completion, you must listen to the entire webinar and complete the evaluation survey. Thank you. Within an hour after the webinar ends, you will receive an email with a link to that survey. Certificates of completion will be sent out via email next week. Please be sure when you fill out your evaluation that you mark whether you want nursing contact hours, CERPs, both, or neither. This program is being recorded and will be available via the Partnership's on-demand education page until September 23rd, 2022. To open our webinar, I'm excited to have Laura Kelly as our first speaker. She's a nurse with 28 years of experience in maternal child health nursing, and also a prepared childbirth educator and international board-certified lactation consultant. Laura is currently the Perinatal Education Coordinator at Hackensack Meridian Health, JFK Medical Center in Edison, and a nurse lactation consultant and breastfeeding instructor at Community Medical Center in Toms River. Welcome, Laura.
Hi, Amy. Thank you for having me this afternoon. Hi, everyone. I'm so glad to be here today to discuss with all of you the use of breastfeeding tools. Many mothers experience some challenges in the hospital when learning to breastfeed their babies. Nurses also in the hospital setting need support and education to assist mothers in teaching them how to latch a baby to the breast. I'm planning to discuss various tools that some hospitals and healthcare professionals can utilize in helping babies that are having difficulty latching to the breast. Why do we use breastfeeding tools? Well, first, to help mothers and their babies to breastfeed. Second, to assist mothers that are having latching difficulties. Sometimes we have to utilize a breastfeeding tool because it may help eliminate the need of supplementation in the hospital. And oftentimes, it helps preserve breastfeeding in certain situations. Preserving breastfeeding situations, it almost seems as if we're kind of like, what do you mean preserving breastfeeding? Breastfeeding should be very natural to a mom and a baby. Well, oftentimes, the anatomy of a mother's breast may not always be what we want to see when we go in on the first assistance with breastfeeding. As lactation consultants, oftentimes we're confronted with nurses in the hospital settings and units when we first arrive on the unit because a mother had a difficult time during the night. And if the nurse had a little bit of more assistance and guidance as we're providing here today with tools that sometimes can be available, they feel a lot more comfortable to reach out and get that tool. Sometimes different hospitals have different policies where you are working in regards to utilizing some of the tools that I'm going to discuss. So I always emphasize to find out your policies and procedures in various settings in order to effectively utilize tools that are available. A lot of them may be under the direction of a lactation consultant or certified breastfeeding counselor. However, if they are available to you, I would certainly intervene with them. So what are some common breastfeeding tools? First, we have a nipple shield. And a nipple shield, I'm going to go into a little bit more detail with it. This is typically a nipple shield that you'll see in settings. And there's various ones that are available. And again, nipple shields sometimes are utilized. The next one could be a nipple everter. And this little item here is a nipple everter. And it's sometimes used to help with getting a baby to latch onto a nipple of a breast. Next are breast pumps. And typically this here is a breast pump. It's a handheld Medela pump that's oftentimes used in many hospital settings. Next are breast shells. And there's different kinds of breast shells that are available to be used, and I'm going to talk a little bit about these. And also another tool, which is kind of not really a tool itself, it's kind of right there and natural, is expressed milk. The mother's expressed milk and nipple creams, ointments, and we have a lot of them here to show you. So different hospitals have various different nipple creams and stuff to utilize, and I'm going to go a little bit more into that as we go on. So, a little bit about nipple shields. Nipple shields can be used for flat nipples, sore nipples, inverted nipples, a baby that may be having a tight frenulum, which sometimes could anticipate being like a tongue tie in a baby, or for excessive engorgement in a mother's breast. Nipple shields themselves come in various sizes. And Medela does have different sizes that can be utilized on a breast if a mother does have, let's say, a flat nipple, which if you look at our little breast here, a flat nipple would be that this nipple itself is totally in, and that can't be everted. A truly flat nipple can't be everted with any type of stimulation or coldness or any type of nipple rolling. So sometimes a truly flat nipple, a shield may actually be a benefit with it, and I'm going to show you how to try to apply it, see if we can get some transfer out of milk of that shield. Again, this is my different types of nipples here, so we can kind of see where it would be utilized. The nipple on the right would be a totally flatter nipple, and the nipple on the left would be almost looking like an inverted nipple. An inverted nipple can sometimes not be everted, and we still may be able to utilize those shields on an inverted nipple itself. So can you go back to the shield? Yeah, I'm going to just go back to my shield slide. Okay, so utilizing the shield. Well, how would you know what size to utilize on a mother with a nipple shield? A nipple shield sizing would go by two factors, size of the mother's nipple and also the baby themselves, the baby's mouth. Sometimes the two may not coincide too well, because if you have a mother with a very larger nipple, the shield itself may be too large for the baby's mouth. So what you would want to do is basically keep the shield as best you can on the size of that mother's nipple, because you don't want the mother to have any negative effect if we're going to use the shield. And we're going to see if we can get the baby to latch on with that shield on the mother. So the both really do have to kind of coincide in order to effectively utilize the tool. As a nurse or as a lactation consultant assisting a mom, you would want to see how the transfer of the milk would act with that shield. You don't want the nipple rubbing against the sides of the shield. The shield itself does have openings on the tip. How to apply a shield effectively onto a mother's breast? You would take it out of the little container that it usually comes into here. And again, there's various sizes. The 24 is the largest type shield, so I'm kind of using that as a demonstrative purpose because it's a little easier for everyone to see on the screen. But the next size that's Medela also makes is a 20, a little bit smaller, and then a 16, which is a very tiny type of a shield, and I know it's kind of hard to see on the screen. These are called contour or cutout shields, which makes it a lot easier when you do apply it to a mother's breast, in order for the baby to still be able to smell the mother's milk and smell the mother's skin in order to achieve latch and a deeper latch onto the baby. When the shield is being used, you also want to make sure that you're actually seeing an effective transfer of breast milk. Shields can also be utilized on a breast if the baby is having a very disorganized stuff, or some babies actually that may have a congenital condition. For example, perhaps a cleft palate, a baby may actually have an easier time to latch onto a breast with a shield if we're having a difficult time, because as the baby does latch on, the breast itself will make a covering underneath that opening in the palate. So sometimes the shield would actually assist them in latching on. So how you would fit the shield onto the breast is the easiest way is, of course, you would want to educate the mother on good hand washing before she was utilizing the tool of the shield, before she applies it. Sometimes if you wet the shield, it makes it easier for application. Oftentimes you may even use a little bit of breast cream on the side of the shield itself in order to apply it to the nipple and to the breast. So you would turn the shield inside out, and you would take your breast and actually take the teeth of the shield and kind of apply it, stretch it kind of over the mother's nipple, and kind of place it to the side. Now, of course, any time that you are working with a mom, you would have to kind of elaborate with her that you would be touching to show her how to effectively latch it on. And again, always, as lactation consultants as nurses, we would let her know that we would be touching her breast to feel and to see if we can get the shield for application on. So the nipple itself is as close, the shield itself is as close as you can get to the nipple. And oftentimes, too, you may want to show the mom to actually hand express some of her milk, because sometimes if you can hand express some of that milk into the shield, it may make it easier for the baby to latch on. And then you would take my baby, I'll grab my baby here, and kind of assist the baby into the shield itself, where you would kind of rub the top of the baby's lip, between the upper lip and the nose, to have the baby open up wide and kind of latch in. What you're looking for is to see if the baby does latch on, that we're getting a transfer of that colostrum, the baby does elicit some type of a response of sucking on that shield. Now, again, you would want to have the top part of the shield up, the cutout part, so that the baby's nose would be kind of smelling into the mother's breast. She would smell the skin of the mother. And again, to assess, you would see the jaw gliding. You would see a little bit of swallowing on the baby to see that the baby is transferring colostrum. During the use of the shield, oftentimes you may want to try to remove it so that you see if the baby can actually latch on. Sometimes with the use of the shield, the nipple will evert and we can get the baby to latch directly on during the shield. The next item is a nipple everter. And many hospitals use this little item, a nipple everter. It's called a latch assist. And a latch assist can actually physically pull out a mom's nipple, if it is a flatter nipple, to get the baby to latch on. The nipple kind of stretches forward and is able to actually kind of evert out. And as you would go to put the baby on, the baby would have an easier time. A nipple everter comes, this latch assist from Lancino, has two different sizes. And again, you would look at the size and the diameter of the everter and then the size of mother's nipple, and you may have to vary it. This kind of disconnect here. and this is a smaller diameter, and this is a little bit larger, but it kind of pops out, and you can utilize it back into the everter. And when you're ready to use the everter, you would want to have your baby ready, meaning your baby should be right with mother at the breast, has already tried some skin with the mother, with the baby, ready to go, because the nipple everter will access the nipple a little bit to come out, and you want to have the baby right there in order to try to get the baby to latch on. So you would have mother's breast. Again, you would still try to have her do a little bit of hand compression, massage the breast itself, position the fingers, press in, and kind of hand express. And then take your everter. You would kind of press in on it, press into the nipple itself, kind of give a little resistance, and then release. And then you could try it again with the mother, kind of in and release. I know it's kind of hard in this little computer setting here to try to see it visually, but the nipple does a little bit invert. You may also start to see that the mother will express some collapsion at this time. So the nipple everter, again, also should be cleaned after usage. Always remind the mother if there is any expressed milk in here, she should be sanitizing it, cleaning it with cold water to kind of release the milk from the sides of it, and then hot soapy water, and make sure it air dries well. The same thing with a breast shield. If the mother is utilizing this breast shield after usage, oftentimes as nurses and in the hospital settings, we'll often find it just laying on a bedside stand and not being cleaned. And we always want to remember, after use, she should be washing it out with cool water first, then hot soapy water, and then letting it kind of air dry a little bit, and keeping it in a clean little case or somewhere clean for the next time for usage. I also tell moms with the shield and any of their breastfeeding tools, this one, the shield especially, it should be sterilized at least once a day. You can put it in the little steamer bags, but always read the manufacturer's directions on it, just to make sure that it can be utilized in that way. So the nipple everter, a lot of moms have really, in my setting, utilized it. A lot of nurses utilize it a lot. The next item that I have on my slide is a nipple aspirator. Just trying to grab that one a little closer. And I'm just many hospital settings don't have the nipple aspirators, but a lot of times mothers may have it. It almost looks like kind of like a little, you may see it on the market as a NIPPLE. It's kind of a little dome-like apparatus that you can actually, a little syringe kind of goes onto it. You kind of position it in and like popping off a little bit. You can kind of put it onto the nipple itself and kind of pull out the nipple with the syringe. Again, they're not utilized in many hospital settings, but they are out there. So if a mother does talk to you about it, because oftentimes a mother may have done some research about her nipples and know that they may be a little bit flatter with the baby's having issues, so she may question you on that. But again, most hospitals usually use the latch assist that are here. Does the latch assist have to be used all of the time? Not necessarily, because oftentimes after the nipple does evert for a while, it could come out. Next that we have is a breast pump, and a breast pump oftentimes can be utilized to help the nipple mother establish milk supply, or to kind of evert the nipple a little bit, on stimulation of the nipple and expression of milk to kind of have that nipple ready to go for when the baby is on. And oftentimes breast pumps can be utilized as a hand pump. One thing that you want to remember is that you don't want your nipple rubbing against the side when it's utilized, that you're able to get a nice little flow and elicit a response of milk, so that way it's easier to get the baby to latch on. So sometimes a breast pump, again, can be utilized to help as a tool with breastfeeding and getting the baby to latch. Another thing that we see with mothers, over my slide a little bit, is breast shells. breast shells can sometimes be utilized. Years ago, they utilized them a lot to help evert a flattened nipple in the last trimester of pregnancy, and it's not recommended as such anymore in this setting because of the fact that you're kind of setting a mother up. Well, you have flat nipples, you're going to set them up for that there's going to be an issue or concern. But breast shells can sometimes be utilized in the hospital if the nipple is flat. It's recommended to be placed on about 30 minutes before baby is going to feed. And oftentimes that may be a little unpredictable because we're emphasizing to moms about feeding on baby's cue when baby's showing hunger signs. So how are you going to know to put on a shield prior? But if it's been maybe about 2 hours, so you can say to the mother, you may want to put on this shell just to kind of help the nipple to evert. It has 2 different type domes. This one would be the one to evert out. And then there's also a outer dome one here, which can be used if a mother is having a very sore nipple and it has more of the backing that's rounder and open more, so that if the nipple is very sore or tender from the way a baby has been latching, it's not rubbing on the tip of mommy's bra or clothing. So sometimes comfort measure to show. But again, we always emphasize them not to wear them extensively, never to sleep in a shell, but they're not utilized that often anymore of the shells. But I wanted to try to discuss them very briefly. A big factor that many nurses encounter and lactation consultants is we go into a room and a mother has a very sore nipple. And the diagram here is a nipple that has been having some trauma to that nipple and is very reddened and abrased. What is recommended is some moist wound healing in sore nipples because it does help in skin repair. It's a balance of moisture within the nipple itself that's kind of keeping the nipple moist inside to heal from the inside out so that we're preventing any scabbing and crusting. Oftentimes, if a scab and a crust forms on the tip of the sore nipple, the baby then goes to latch on and disrupts the scab, and then we're starting over again. It's never really healing. So things that are maintained with soreness with that is a normal moisture balance decreases the pain nerve endings on a partially covered and protects the nipple itself from outside stimuli. So the moist healing could be utilized with cream, lanolin. Okay, lanolin is typically there's different lanolin creams, but the Lancino that's used in hospital settings is Lancino, and it doesn't need to be washed off. It can just be applied very sparingly to the nipple after each time of breastfeeding. Medela also makes a tender lanolin that is heat purified that can be applied to the nipple after breastfeeding. And then also, actually, mother's milk, her breast milk itself, can be applied to that sore nipple for healing. There's also another cream that oftentimes moms utilize. It's called Boost cream, organic nipple cream. But you always want to emphasize to moms whenever they're utilizing any type of cream, if they have any allergies to anything, especially wool allergies. Lancino is usually a contraindication with the lanolin if they have any type of wool allergies. And always make the moms aware they should be keeping that area clean, that sore nipple, with warm water and patting it dry when utilizing. Another thing that's sometimes used as tools in a hospital setting are hydrogels. Hydrogels are a gel type of pad that's applied to nipples, and they heal. There are different ones that are there. These are hydrogels from Medela, and you would want to emphasize to read the directions on them. Sometimes they have to be wet before the first application. It's a jelly-like that's peeled away, and the Medela is good for 24 hours, and it kind of heals. It maintains moistness, and it's applied to the nipple over, and it kind of gives a little dressing onto that soreness or an abrased, traumatized nipple. After removal, very gently, when the baby is going to nurse, With the hydrogels, we do want to emphasize the mom to make sure she is washing her nipple before the baby goes to feed at this point. So the hydrogels, you do have to utilize that. This is the Medela hydrogel. There's also Lancinol makes what's called a SUVI, and they're very similar. And some hospitals will have the Lancinol SUVI, which is basically very similar with a hydrogel type of dressing to be applied to the nipple for healing. With the hydrogels, you want to make sure that it's not used on a nipple that is infected, because of infection is a contraindication for that use of the hydrogel. Because oftentimes with an infection, a mother may experience a little bit of a vasospasm and some blood, an occlusion on that area. And a vasospasm may be where the nipple type of blanches, so you wouldn't really be wanting to utilize that on that type of situation. So there's various tools that I've kind of talked about here today, and if they are utilized, please consult with if you are a nurse in a healthcare setting with your lactation consultants or breastfeeding support for mothers. And as you can see, we have a lot of different tools, but you want to let mother know that we're here to assist her and that there's various items to be used.
Thank you, Laura. That was terrific. We do have some questions that have already come in the question box. I just want to remind the audience that they can write questions in, and hopefully we will try to address as many as we can before our next presenter. So the first question is about nipple cream, and Joanne wants to know if nipple cream is hypoallergenic.
The hypoallergenic, the Lancinol is. The Lancinol is a hypoallergenic cream. Various ones that are on the market, though, they should make sure if they are buying them here outside of the hospital setting, to just make sure that they're reading all of their manufacturer's directions on them.
Thank you. And Gina asked, why use cold water first to clean the nipple shield?
Oftentimes, Gina, what we come to find is that the milk itself can sometimes stick even with the hot water. So sometimes the cold water will actually release it from the sides of it, and it might help to release that milk when you're first going to wash it out.
Are nipple everters and nipple shields easily available? And does insurance cover some or all of those costs?
Well, that's a very good question. Various stores do sell things on the public that are out there, the EVERTERS, different stores that I've seen them in, or Amazon. Years ago, and of course, we had the Babies R Us. They always had a very big supply, but they are available, EVERTERS, and insurance should be covering for breastfeeding supplies. You have to check with each insurance, but because of the act that was initiated with support of breastfeed pumps and equipment, it should be covered, but I would check with your insurance on it individually, because each of them have different stipulations on what they are covering for breast equipment. But when President Obama came in and put in the Affordable Care Act with the health care assistance with breastfeeding items, breastfeeding supplies and pumps were utilized. So I would definitely try to see if your insurance does cover it. But definitively, I couldn't say specifically.
Thank you, Laura. And here's a question from Claudia. Can you explain what a true flat nipple is again?
A true flat nipple, kind of show it on my little display here, doesn't evert with nipple rolling and with stimulation. It's still going to remain flat. It's it's kind of hard on a web setting to have it out there, but it's not going to do any inversion. It's just going to stay flat itself. It's a little bit different than a totally inverted, but a flatter nipple will have a hard time to invert. But it sometimes can come out with the usage of, different apparatuses that are showing.
Thank you. And here's a question from Patricia. Do you need to wash the nipple breast areola prior to feeding?
We've come to find out no, Trish. Trisha, I think it was. We don't need to wash prior to feeding unless there's been a gel left behind if you use the tool. We do want to emphasize to moms that they should be maintaining good hygiene, showering daily, keeping their breast area clean, but you don't have to vigorously be washing at the nipple and areola prior to latching a baby on every time to the breast. It tends to dry out the mother's skin, and you don't need to do that.
And Leslie has a question about the hydrogel pads. She's asking how helpful they are.
It varies in every mother, every type of tool that's utilized. Mothers, of course, respond to different types of treatment. Basically, hydrogels can help. It really depends on the mother and how her pain has been and why it's being used. Was it just for some soreness? Was it for a crack, an extensive amount of, let's say, damage in the nipple? So it varies, but in my experience, for the many years of using it in a hospital setting, I've had moms that I have given a hydrogel care to, and the next day when I've come in to help them, they were like, oh my gosh, this is like a godsend that you gave it to me, and I feel so much better. Thank you so much. With utilizing a hydrogel too, you shouldn't be utilizing the nipple cream. It's kind of one or the other at the time of application. If you're utilizing a hydrogel, you shouldn't be using the nipple cream, like a Lancinol. It's one or the other.
Good to know. I know that you've mentioned Medela products, Medela breast pump, but of course there are other breast pumps that can be used for patient care. Did you want to mention any of those?
Sure. Some hospitals, it depends on if you're working in a hospital setting. And again, my expertise has basically been in the hospital setting for many years. Some hospitals use Amida pumps, also hand pumps, or Amida electric pumps as such. Sometimes with a hand pump, though, with the Amidas or with the Medela, sometimes the mother has more control with breastfeeding at times, and also with pumping her breast milk and everting the nipple. There's also a Lancinol hand pump. So various hospitals have different pumps available. It just depends on what's available at your facility. Basically, they all have the same type of mechanism, but again, just like other products out there, everybody prefers different things over another. I'm just utilizing that one today because that's what I have available here.
Thank you. Thank you so much. Do you suggest any specific position for breastfeeding when a mother is experiencing nipple pain?
Sure. A lot of times the best position is kind of a laid back position. What you can do is you actually have your baby, and this is my little demonstration baby, as we call her. The laid back position is where the mother would kind of recline as she's here, and your baby would kind of just be kind of laid back on you, and you would direct your baby to the nipple itself area. And of course, just like you were latching a baby on, you would want the baby to come in first to the breast with the chin touching into, my breast touching in first. But the laid back position usually does help because you're actually utilizing gravity to kind of reabsorb, let's say if the breast is very full, and it kind of is more of a comfort the way the baby's latching into the breast. So the laid back position is usually recommended.
Great. Well, thank you so much, Laura. I think we're out of time for questions and we have to move over to Sarah.
Okay. Thank you so much, Amy.
Well, Sarah will be back with us shortly, hopefully. In the meantime, let me introduce her. Sarah Muller-Robbins also works at Hackensack Meridian JFK Medical Center in Edison. For the past 5 years, she has been the hospital's lactation coordinator. Sarah is a nurse and a lactation consultant with a background in public health. Welcome, Sarah.
Thank you, Amy. I'm happy to be here today. How is my sound, okay?
It's good. Thank you.
Great. So today I'll be talking about paced bottle feeding. And what I did mention to someone that I am talking about bottle feeding, and the response was, this is a breastfeeding conference. Why are you talking about bottles? But
Sarah,
as anyone who, oh, yes.
Sarah, this is Laura. I just wanted to remind you to change your name on your screen so that everyone knows who you are.
Yeah. I am not Laura Kelly, although we spend a lot of time together. Thank you for that reminder. Good. Okay, good. Thank you. So in the hospital, bottles are ubiquitous. We all work with bottles. A lot of breastfeeding families do end up giving bottles for many different reasons. And so what I want to talk to today is about different reasons why families do give bottles, and the education we should be giving families when they do are giving a bottle, and then just how to do it in the paced bottle feeding way. So the common reasons that babies are often given a bottle in the hospital setting, one thing I notice a lot is for a sleepy baby, that families will say in that first 24 hours, they're so surprised how sleepy the baby is, and they get concerned and believe the baby needs to get a little bit more. And on the other side of that, when babies cluster feed, a lot of parents will get concerned that the baby's feeding again and again and something's wrong. And so our job is really to educate them on the typical newborn feeding patterns and how that can be normal. Another risk factor if the baby is a late preterm infant. This is a baby born before 37 weeks gestation. So that we know that babies who are born a little bit early they may lack the strength and coordination and the stamina to establish early breastfeeding. So these babies are at higher risk of needing to be supplemented. And then we also need to remember sometimes if the baby is an SGA, born from a gestational diabetic mother, that the baby may look 40 weeks, but actually be 36 weeks. And so we have to remember not to treat the baby as a full-term baby, but to realize this baby has some risk factors for feeding. Hypoglycemia kind of relates to that too, because if a baby is a preterm baby, gestational diabetes, that baby is going to be at higher risk. And for hypoglycemia, especially if it's very low, that baby will need to be fed right away. And of course, the main goal of any infant feeding is that the baby is getting sufficient intake. So if there's any indicators the baby is not, that baby will need to be fed and sometimes be supplemented. So I like to think of this like a puzzle piece. You know, it's what we look for. How is the baby latching on, positioning and latching on? Is the baby transferring milk? How is the baby's output? What is the baby's weight? All of that together can give us a clear picture. And of course, if there's any indications that the baby is not getting sufficient milk, we need to make sure that baby is fed. Another risk factor for a baby being supplemented is having hyperbilirubinemia. If the jaundice level is increasing, the bilirubin is increasing, the Academy of Breastfeeding Medicine does not recommend that we automatically supplement a baby with high bili levels, but we do know that's a risk factor. If they have any symptoms, any symptomatic hyperbili, then we want to make sure that that baby is fed. And then, but the most common reason that I have found is that parental request, when the parents just ask for that supplementation. And so our job is to make sure that that parent is educated. We want to support any decision that the family has. But of course, if the family don't know of all their options, is it really an informed choice?
So our job, if we're nurses in the hospital, if a family does ask to give a bottle, is to understand the reason why. And I'm guilty of this, that sometimes if a mother may ask for a bottle, I may go into my whole education of why the baby should stay on the breast, and not really realizing the reason that she asked for a bottle is that she's going back to work in 2 weeks. So we really want to understand where she's coming from and make sure we address the issues that she's dealing with. And so we also want to be able to educate her on what specific issues or why the family is asking, talk about the benefits of directly breastfeeding, some of the negative consequences of starting a bottle in a non-judgmental way, and then offer alternatives. So they have choices, and then of course supporting their decision. And so one of the important things, if a family is giving a bottle, is to make sure that they understand the appropriate amount. So often one way to do that is I've even carried around a marble with me, and to be able to show that this is the size of the baby's belly when they're born. I have found a lot of families will talk about they've seen other babies feed with a bottle, and they're getting 4 ounces and 5 ounces, and they know the mother knows she doesn't have 5 ounces in her breast. And so I like to tell her, no, you don't, and you don't need to, because this is the size of your baby's belly. The one drawback of that, though, I've noticed is that sometimes the families will say, maybe they did give a bottle and the baby took 30, 40 milliliters. And so that is not, I'm going to turn off my video for just a moment. So they say, well, look, my baby's stomach was bigger. So that may be an indication, that the baby's stomach can stretch. So even though it's that small, that's how much they're supposed to have. One thing I like to do is to show just a little teaspoon. I carry these in my pocket and say, this is a typical feeding. And so to try to change their mindset that we're not looking at a 4-ounce bottle, we're looking at a teaspoon. The first 24 hours, it's estimated that babies get between 2 and 10 milliliters. So to show that this fills up to the top, it's 5 milliliters. A lot of times you can see families saying, wow, maybe I do have enough milk, if that is their concern. But what's also important is that they understand how much, if they are getting a bottle, how much the baby should be getting. So I like to tell them typically not more than 10 milliliters per feeding that first day. And if they are giving the formula bottles we have in the hospital are 60 milliliters. So when they get that, there is this assumption that this is a feeding, so we really need to make sure we educate them. You can see in the picture here that day 1 is a very, very small amount. So I'll point to the bottle and say this is really the appropriate amount in that first day. If a mother is expressing her milk, hand expression or pumping, and a lot of times she'll have just a little bit at the bottom of the bottle and feel discouraged. So it's very important that we celebrate anything that she can have and really educate that this is actually an appropriate amount for your baby to get. What we also want to do is talk about alternatives to bottles. So there are other ways if the baby does need to be supplemented, whether it's for a medical reason or for just a parental request, that they're all alternatives. So this card we have here, we use it from Noodle Soup Company, and what I really like about it is it demonstrates how to do hand expression, and I love how it has a picture of a baby being spoon-fed. I've noticed a lot of parents cannot even imagine spoon-feeding a newborn, but when you can show them that picture, that really gives perspective. Oh, maybe I can do this. Also, a medicine cup is for a little bit larger amount. And so this can be done with expressed breast milk. If the baby does need to get formula supplementation, the spoon or medicine cup can be a great way of giving a little bit more. And then also we have the supplemental nursing system, the SNS. So that's really a wonderful way for a family that really does want to breastfeed, but the baby is getting supplemented, of being able, the baby is learning how to breastfeed during the supplementation, and that we know will not interfere with the latching on the breast. So as we talk about the avoiding a bottle and trying to stay away from the bottle, it's important to understand why. Why are we trying to avoid this? This is one handout from the Lactation Education Resources. You can get this handout online, and it's completely free, and they give permission to distribute it to families. What I like about it is it really demonstrates the difference between the bottle and the breast. So I can just pull from what they have in their handout, looking one by one. With breastfeeding, we know that the breast is soft, it changes shape, versus a bottle, which is very firm and it doesn't move at all. With breastfeeding, the nipple really should be positioned towards the back of the mouth and really go towards the junction of the hard and the soft palate. Versus bottle feeding, that nipple stays right in the front of the mouth, right at the hard palate. And so during breastfeeding, the nipple changes shape, it elongates, it goes towards the back of the mouth versus, of course, the bottle does not. And not only the shape of the nipple, but the flow is very important and very different between the two. So if for breastfeeding, the baby's on the breast, they might get a little bit of milk, but it isn't until the pituitary gland is stimulated, oxytocin's flowing, it squeezes the smooth muscle of the alveoli in the breast that the milk really starts to flow. Versus on a bottle, of course, it flows right away. With the breastfeeding, it starts off slow, then you have a fast letdown, and it slows down again, versus the bottle, where it comes fast the whole time. And you may have heard, I've had a family say, maybe they're breastfeeding, decide to give a bottle, and look, the baby took the whole bottle in 2 minutes, and they're excited about it, and I try to describe that's not how really the babies are supposed to be feeding. Typically, for breastfeeding, it takes 30 to 45 minutes, versus with a bottle, it can be very quick. And also with the way that the baby sucks. With the breast, the tongue moves, makes the peristalsis movement, versus on the bottle, they could even almost like a biting motion and still get milk out fine. As well as at the breast, the tongue is tucked forward around the nipple. For the bottle feeding, that the tongue can be kind of humped back. So the difference is, you can see these two babies latched. The one on with a shallow latch, that baby's latched on kind of like a bottle. And so how is that going to impact if this baby goes on the breast, if the baby's on the breast like a bottle? Well, I'm sure anyone who's breastfeeds sees this might wince a little bit, that if the baby is really at the tip of the nipples, that mother is going to get some sore nipples and have to turn to Laura with all her tools to deal with it. Then if the baby's not latched on as deeply, is latched on more like a bottle, that baby's not going to get as much milk from the breast. And then we know if the baby's not transferring milk effectively on a consistent basis, that mom may struggle with milk supply later on. So giving a bottle in that first few weeks, as the baby's learning how to feed and latch on, can really affect the breastfeeding relationship for that mom. So we're talking a lot about this as far as going back to the breast, but I'd like to talk about this too, is for, now can you still see me, Amy?
Yes, we can see you.
Okay, great. But even we still, as lactation consultants here, we'll see families that are only bottle feeding and have no intention of breastfeeding, because we want to make sure that they learn the appropriate way of breastfeeding. Of bottle feeding, because the really fast flow, that more of that shallow latch on the bottle is not the physiologically normal way for a baby to feed. So there has been some studies that demonstrated that babies who bottle feed and don't go to the breast, even if it is the mom-born express breast milk, that baby's going to be at higher risk of obesity, can be a higher risk of obesity later in life, because that baby is that the feeding can be overcome. Rather than the baby's feeding cues, it can flow quicker than what's intended. So what's important is whenever a baby gets a bottle, whether that baby is breastfeeding, it's combination feeding, or is exclusively bottle feeding, that we do it in the most appropriate, physiologically normal way for the baby. So the way I describe it to parents is that we want to pretend like we're breastfeeding. But the one thing that necessarily happens with breastfeeding is that contact that the mother and baby have, the skin-to-skin contact, that connection that they have. A mother who's bottle feeding, or any parent who's bottle feeding, should be able to have that same connection, even if they're not giving the breast. So we want to make sure that the baby's held close, that there's opportunity for eye contact. And so then we also want to make sure that the baby's sitting up. One of the big problems is we hold the baby like this, what you can see actually in this bottle, barely touching it, that the milk or the formula can just come out with barely touching the nipple. So we don't want it to come out. We want it to be more like the letdown of the breast. So instead of having the baby laying down, we have the baby sitting up, either holding upright with a hand behind the shoulders or holding in the arm. So also we want to make sure that the baby opens deep and wide. We don't want that baby to kind of be on the tip of the nipple. So I like to start having the baby open up wide and kind of tickling towards the top of the mouth, towards the roof of the mouth. And ideally waiting till that baby opens deep and wide. And so as the baby opens wide, kind of putting it towards, and with the narrow nipples like this, we want the baby to almost feed towards the collar of the nipple, not just here at the tip. So a deep, wide latch. Now, we don't necessarily want it to come out right away. So we can even hold it so the baby is not getting milk right away. And then as the baby is kind of sucking in a rhythmic motion, slowly lifting it up. And then we can have a few sucks, a few swallows, and then lowering it again. We know that that's how they feed naturally on the breast. They suck and they rest, suck and rest. So we want to mimic that with the baby. So if it's a wider tip nipple, then we just want to make sure the baby's lips are nice and relaxed and flanged out. Sometimes for the wider tip nipple, that the baby can kind of just be towards the end and actually have a more pursed, almost like sucking on a straw. We want to make sure the baby's nice and relaxed and deep and wide. So it's a kind of lift and bring it down. Some will even suggest taking the nipple completely out of the mouth and then putting it back in. But I like to just kind of give some breaks and watching the baby. So we don't necessarily, we should always say, make sure that the nipple is completely filled because the baby will get too much air. But one way to think about it is if you're sipping on a little cup of tea, or you're taking a water bottle and chugging, which one are you more likely to get some air and maybe even have a burp? So more if it's chugging. So when it's forceful feeding, that's going to lead to more air and more gassiness. So think about that of just having the baby sipping on a cup of tea and giving them breaks. And of course, we do want to make sure that we burp afterwards because the baby may take some air. So what we really want to teach the parents is feeding cues. So much like we do with breastfeeding, we want to make sure the signs that the baby's hungry, and then signs that it might be too much for the baby, because babies and we can't swallow and breathe at the same time. So following the baby, if you see a wrinkled forehead, the eyes widening, the hands playing like this, and he's squeaking, or even choking, to make sure we pull it down, really following the baby, watching the baby's lead. And then also signs when the baby's done. So that can be that they just get sleepy, they may turn away from the bottle. They may just kind of, as you pull it down and tickling, they're no longer rooting and looking for it. And then we want to respect the baby's cues and stop the feeding. It can be really hard. If you have just a little bit of breast milk in here, especially when you work really hard for the breast milk, to not want to stuff every single drop in the baby. But it's really important that we do respect the baby's cues, both feeding cues and the fullness cues. And so this is important for, particularly if we know that the baby is going to continue to breastfeed, but also later on, a lot of families decide to give bottles later on. What's recommended for a breastfeeding baby is to avoid starting that bottle until the breastfeeding is well established. Like typically the signs of that, the baby's gaining weight well, a good number of wet and dirty diapers, the mother is comfortable breastfeeding. Typically we'd say that's about a month or so. So if breastfeeding is well established, and because a lot of mothers will be going back to work, for whatever reason they want to give a bottle, that's typically a good time to introduce it. Now I run Laura and I have a mother support group here. And so one of the big stress a lot of mothers have, or they'll give us a call that as they go back to work that they really struggle with milk supply. And so what I always want to tell the mothers is make sure your caregiver knows case bottle feeding. The reason for that is if the caregiver is, every time the baby moves and shows any signs, keeps feeding and keeps bottle feeding and gives an oversupply and overfeeds that baby, that mother is going to really struggle at pumping enough milk while she's working to be able to maintain exclusive breastfeeding. The other issue with that is that babies get a certain amount of milk in a 24-hour period. So say a mother and baby are separated for 8 hours. So we'd assume that the baby might get about a third of the caloric intake during that 8 hours. If that caregiver is not doing case bottle feeding and really overfeeding that baby's going to be full. And so typically when mothers are working and they're back with their baby, we know that the baby can stimulate her milk supply better than the pump. But if that baby was overfed the whole time they were separated, this baby's not going to feed as much when they're back together. So a mother who has a caregiver overfeeding and not doing the case bottle feeding is more likely to struggle with milk supply when she's back at work. So what I tell families if they know they're going to be introducing bottles is to go on the lactation education resources. I'll give them a handout. There's a lot of wonderful videos on YouTube on how to do paced bottle feeding, and I'll encourage them to have their caregiver watch one of those videos or give the handouts to their daycare, because that can really help support continuing breastfeeding as they continue on in their journey. So I welcome any questions that anyone has.
Thank you, Sarah. That was a great presentation and so useful, especially when you're talking about people considering going back to work and still trying to support breastfeeding. So we do have a few questions that have come in. And the first, oh my goodness, now they're really coming in. Thank you. Yes, please continue to put questions in the question box. This is from Patricia. She asked that if you could please repeat who states that supplemental feeding is not the first choice for hyperbilirubinemia.
I'm sorry, say it again.
Patricia's asking if you could restate which professional organization states that
yes.
Supplemental feeding is not the first choice for hyperbilirubinemia.
That is from the Academy of Breastfeeding Medicine. They have protocols, and on their protocol for supplementation, I believe it's in the hospital setting. When it comes to hyperbilirubinemia, they say if the baby's not symptomatic, they don't recommend automatically supplementing. It may be needed if hyperbili is a symptom of the puzzle that the baby's not getting enough milk, or if the bilirubin's dangerously high. But that in itself does not necessarily mean, according to the ABM protocols, a baby necessarily needs supplements.
Thank you for clarifying. This next question comes from Zelen. Any tips on how to introduce a bottle to a baby that is only breastfed and is declining the bottle?
Yeah,
I had one of those.
Yes, I had one later on in life too. And so typically what we recommend is introducing a bottle about a month or so, and continuing to do that. That being said, I've known families that didn't introduce the bottle till 3 months and it was not a problem. Others who introduced it early on and gave it regularly, and then all of a sudden the baby stops and doesn't want it. So some recommendations, if the baby's been breastfeeding, to make the breast milk 98.6 degrees or around body temperature. The other thing can be sometimes we'll heat up the milk, but not the nipple. So sometimes even having the nipple warmer, even dipping the nipple into some of the mother's own breast milk so the baby can taste that can be helpful. I've had some mothers say that they found it was helpful if they were the one to introduce it, that really kind of working like they're breastfeeding and give the baby would take it from the mother. I've heard others say if the baby knows that the mom is anywhere, can smell the mom, that they won't take it, so the mom may leave. I've heard some say it works best if they were walking around, giving distractions and putting on and then feeding, that the baby would be distracted. Others would say they'd have to turn down the lights, go in a dark room, and decrease any distraction, because if there was a movement on the other side of the room, that baby would lose her. So unfortunately, I have no one-size-fits-all answer, but that's why I love the support groups. I know the partnership has them. We have them because mothers can we don't have the evidence to show this will always work, but hearing from other mothers is really helpful.
So true, so true. Here's a question from Suzanne. Some mothers ask, what is the best nipple to use? What do you recommend?
I have tried to do some research on this, and I also haven't been able to find good evidence to support. But what I have found is for majority of babies, making sure that the nipple is symmetrical. That we used to use a lot of the nook nipples or the flatter ones, thinking that might be better for a breastfeeding baby. But it's found that sometimes that can collapse when the baby's feeding. Of course, for some babies that does work better. And then the more I've been reading and researching, it seems that I've had some mothers say that the wider base nipple works much better for a breastfeeding baby, and others say no, because the baby tends to be more towards the tip, so the more narrow one seems to work better as long as the baby's nice and wide. Anything that I have seen is to make sure that that it's a technique is the most important thing. One thing we also want to recommend too is that we have, in the hospital we used to use just regular nipples, but now we have the slow flow. And we actually we use it for breastfeeding babies, but now we use it for all babies, even those who have no intention of breastfeeding, so that they don't get quickly overfed. But again, no one size fits all, unfortunately.
If a baby gets a bottle, what can a breastfeeding mother do to help the baby go back to the breast?
That's one of the concerns and why we encourage mothers to try alternative methods before giving the bottle here in the hospital, because I used to always get calls, and once I gave the bottle, my baby won't latch anymore. So the things that I'll often tell the mom is to do a lot of skin to skin. There's something about that baby's torso against the mother's that just kicks in their natural instinct, and they might start to go for it. Typically what we say is to breastfeed first, and then then always wait till after. But for those cases, sometimes I'll say, if the baby's been giving a bottle, give a little bit of the bottle, calm the baby down, and make sure they're still a little bit hungry, but not super hungry. And doing the skin to skin, sometimes, as Laura was mentioning, that laid back positioning, that just kind of, rather than us trying to force the baby on, that baby can kind of go at their own pace. But again, much like going to the bottle, sometimes the limiting distractions help, sometimes adding distractions help. But certainly working with, talking to other mothers or lactation consulting can really work with specific cases.
And then a last question, can a tongue-tied baby who has difficulty breastfeeding bottle feed?
That's one reason why sometimes the families will decide to give a bottle, because if the baby does have any restrictions of the frenulum, breastfeeding can be painful. However, sometimes babies will also, a sign of having some restrictions and tethered oral ties is when the baby is even bottle feeding. It dribbles out of the side of the mouth. So that's not always the solution. So if there is signs that a baby is even having trouble latching on the bottle, is dribbling out the side of the mouth, the recommendation is to get the baby assessed by a lactation consultant or a provider who's skilled in the assessment, because it can affect any way that the baby is feeding.
Great. Thank you so much, Sarah. I think that's all we have time for today. Great job.
Thank you.
Thank you to Laura, too. I know she's in the background. Could you go back to sharing your slides so we can get the last slide up? In case people have questions, I want them to be able to reach out to me, and I'll be able to reach out to our speakers to provide any answers. So again, I want to thank both of our wonderful speakers, Laura Kelly and Sarah Muller-Robbins, and of course to Laura Hall, who's been handling the technical background of our program. A reminder to all the attendees that in about an hour, you'll receive an email with a link to the post-program evaluation, and that certificates of completion will be sent out next week via email, and we'll use the email that you provide on the evaluation, so please check it for typos. In October, the partnership will be acknowledging Domestic Violence Awareness Month with a 4-part webinar series. The first program, Domestic Violence, Understanding the Dynamics and Impact of Power and Control, will be broadcast next Thursday, October 1st. We will also be providing a webinar on perinatal grief and support as part of our Perinatal and Infant Loss Month activities, and that webinar will be held on October 13th. In addition to our webinars for professionals, the partnership has a variety of resources to support new mothers who are breastfeeding. Our Sisters Who Breastfeed program in Paterson and Jersey City is a collaboration with the Perinatal Health Equity Foundation. This support village for Black women helps them with breastfeeding, and if they're planning to breastfeed, and it also offers virtual support, connections, and resources. For more information about education programs for professionals and resources for moms, infants, and families, please check out our website at partnershipmch.org. Thank you again for all those who joined for today's program, and I hope you can be with us next week.